Hello everyone, I am Pranjit Mittal and today we'll do our cardiology session. Okay, so I'll try to cover all the important topics which have come in Krok exam from cardiology, and we'll try to cover all these topics in depth so that we can solve the new questions also. Okay, so cardiology. So the most important topic in cardiology is ECG, right? So every year we get 2 to 3 questions on ECG. So in ECG, we'll start with AV blocks, right? So what AV blocks are, I'll tell you the normal conduction pathway first. Okay, see, there's SA node, we all know, like there's impulse generation in SA node, then they go to AV node, and then to bundle of phase and Purkinje fibers. Purkinje fibers, right? These basics, the things we all know, right? So what happens in AV block is there's some problem in AV node. So if there's problem in AV node, problem with AV node, there will be disturbed conduction from atria to ventricles. So now we have understood what AV blocks mean. Okay. So in AV blocks, there are mainly 3 degrees of AV block. First degree, second degree AV block, and third degree AV blocks. Right. So in second degree, we have further Mobert's type 1, Mobert's type 1, and Mobert's type 2. Mobert's type 1 is also known as Van Kebeck block. This Van Kebeck block. Okay. So I'll start with first degree block. Okay. So firstly, I'm making the normal ECG. This is P, Q, R, S, and this is T. So I'll mark. This is P, Q, R, S, T. So this is normal. From the starting of P wave and till the starting of R wave, we call it PR interval. Right, PR interval. So what happens in AV block is there's PR prolongation. So the normally PR interval is 0.12 to 0.2 second. So max to max it can be 0.2 seconds. Okay. If in the Krok question they give you in like ECG question they give you this PR prolongation, or they give you the interval like PR interval is more than 0.2 seconds. So you should understand that this is a question of AV block. Okay. So in all AV blocks there's PR prolongation or PR interval more than 0.2 seconds. So same thing, right? So in first degree AV block there's PR more than 0.2 but no missed beat. So I'll tell you what. So in second degree AV blocks there increased PR interval, right? This P, Q, R, S, T, again P, Q, R, S, T, like this, right? So there's PR increased. Let's say this PR is 0.22 second, this PR is also 0.22 second, this PR is also 0.22 second, and there's no missed beat. So all P, so every P wave is followed by QRS. So every P wave is followed by QRS wave, right? This is the meaning of no missed beat. So in first degree AV block, there's only PR prolongation. That's it, nothing else. Okay. So this PR prolongation can be physiological in most of the cases. So in which physiological conditions we can see first degree AV block? In athletes, okay, or any person with increased vehicle turn. So if there will be increased vagal tone, there will be PR prolongation, and usually we need no treatment required, right? Why we don't need any treatment? Because these patients are usually symptomatic, and some persons, they are not even patients, they are absolutely fine athletes, okay, and they, like, whenever we do ECG in them, we might find first degree AV block in second degree AV block. So for our Krok question, second and third degree AV blocks, they are very important, because many times they have asked questions second and third degree AV block. So in second degree, we have Mobitz type 1 and Mobitz type 2, right? And Mobitz type 2. It's type 2. So what happens in Mobitz type 2 or type 1 is there's PR prolongation, and which is progressive PR prolongation, right? And then there's a missed beat, right? So I'll make you an ECG here. Then there's increased PR prolongation, then more increased PR prolongation, and then there's no beat further, and then again P increase, like this. Okay, so what happens in Mobitz type 1 or Vankeback block is there's PR interval, let's say here it is 0.21 second. In the next beat, there's 0.22 second. In the next beat, there's 0.3 second. So it is progressively increasing. So there's progressive increase in PR interval, right? And then there's one missed beat, so which is followed by missed beat. So there's a missed beat. Missed beat means there's no QRS, okay, after a P wave. Cool. So this is Mobitz type 1. In Mobitz type 2, there's PR is prolonged, but this is not progressive. So, and there can be missed beat anywhere. Missed beat. Okay. So there's PR, PQRST, PQRST, and now P and no beat. Again PQRST, PQRST, like this. So there's normal rhythm, right, till here, and now here a missed beat comes, right? So in Mobitz type 2, there can be missed beat at any place. Okay, so it's not like we see in Mobitz type 1, there's increased PR prolongation, so progressive. So in first beat, PR is like this, 0.21 second, like 0.22 second, 0.23 seconds, and it is progressively increasing. So progressive PR prolongation is there, and then a missed beat comes. In Mobitz type 2, missed beat can come at any place, right? So I'll just summarize it here. In Mobitz type 1, there's progressive PR prolongation, and then comes a missed beat. Comes a missed beat. Comes a missed beat. And in Mobitz type 2, there's PR increased and missed beat. So there's no progressive PR prolongation, right? And these both belong to second degree AV block. Second degree AV blocks. Cool. Then there's third degree AV block. Third degree AV block. So what happens in third degree AV block is there's no relation between P wave and QRS wave. So atrium rate is not equal to ventricular rate. What does it mean is, so atrium, they are contracting on their own pace, and ventriculars, they are contracting at their own pace. So I'll give you an example. I'll show you the ECG. Okay, let's say there's a P wave, atrial contraction, atrial contraction, atrial contraction, and they are not related to this QRS wave. So QRS might come here, and it might come here, then it might come here, it might come here. Okay, so the ECG will look like this. Okay, so there's no relation left. So PP interval not equal to RR interval, and they are like there's definitely no relation left. No relation between atrium and ventricles. Okay, so I'll take this here. Hmm. So in this image we can see I'll zoom in. Hmm. So in this image here we can see first degree AV block, right? So in first degree of AV block there's PR prolongation. There's increased PR interval, increased, and no missed beat. No missed beat. Right? P and then QRST complex, then one P, then QRST complex, then P, then QRST complex, right? There's no missed beat here. In second degree and type 1, Mobitz type 1. In Mobitz type 1, see, zoom in, there's PR prolongation this time, then it's increasing, then PR interval is increasing, and then there comes a missed beat. Then comes a missed beat, right? So there's progressive PR interval increase, then missed beat. In Mobitz type 2, there's increased PR and missed beat can come at any place. Missed beat can come at any place. See. So this PR is prolonged, this PR, and then comes a missed beat, right? And in third degree AV block is there's no relation between P and QRS. This P wave, this P wave, P wave, P wave, P wave, and then you have QRST complex, QRST complex, QRS complex, QRS complex, right? So there's no relation left between atrial and ventricular rhythm, okay? So how to remember this thing is, so there's a very funny way to remember these things. Let's say for AV blocks, okay? So let's say there's a newly married couple. There's a newly married couple. Okay, so what happens after some time is like there's दूरियां बढ़ने लग जाती है. There's increased distance, increase between them, right? So this is first degree block. Then there's progressive increase in distance between them, and sometimes fight happens. So sometimes fight happens. Okay, this is Mobitz type 1. And now they are not talking with each other, so there's increased PR means there's increased distance between them, and fight can happen anytime. Fight can anytime, right? This is Mobitz type 2, and now they are divorced. This is third degree, and this is just a way to remember, and the ECG I have shown them here. Okay, so for our Krok exam, for Krok especially, okay, for Krok 2, second degree and third degree AV blocks, they are very important. Degree AV blocks, they are very important, okay. They are important. They have never asked question on first degree AV block because this is not pathological as such. Okay, so for second and third degree AV blocks they have asked many times. Okay, so after AV block, we'll go for we'll take more ECGs. So let's take difference between ventricular tachycardia, ventricular tachycardia, and supraventricular tachycardia. This is supraventricular tachycardia, right? To differentiate between ventricular and tachycardia and supraventricular tachycardia, then you just have to see one thing, that is the QRS length. Okay, so the duration of QRS, so you can differentiate between ventricular tachycardia and supraventricular tachycardia. See, normally the QRS duration is 0.1 to 0.12 second. Okay, this is the normal duration of QRS. See, in any patient, in any ECG, if you are getting tachycardia, tachycardia means heart rate more than 100, right? In any patient having, like, you have taken ECG of any patient, and in that ECG you see just tachycardia. So this tachycardia can be ventricular tachycardia, or it can be supraventricular tachycardia, right? To differentiate between ventricular tachycardia and supraventricular tachycardia, just look at QRS duration. QRS duration. If it is increased, that is 0.12 seconds is another, then we call it ventricular tachycardia, right? And if the duration for QRS is normal, QRS duration normal, then we call it supraventricular tachycardia. So any patient having tachycardia can be classified in supraventricular tachycardia or ventricular tachycardia, right? Then in ventricular tachycardia, in ventricular tachycardia, we have understood that there should be a tachycardia with wide or broad QRS complexes, right? Then we will call it ventricular tachycardia. There are two types of ventricular tachycardia, so I'm not going into depth, but like, it's better you know about them. There's monomorphic ventricular tachycardia and there's polymorphic ventricular tachycardia, right? Monomorphic ventricular tachycardia means all the QRST waves, they look like same. Okay, so I'm making an ECG here. See, like this. Like this. Okay. So all the QRS complexes, they are broad. There's tachycardia present, and all beats, all ECG, all QRS complexes look similar. Looks similar. Then we call it monomorphic VT. Monomorphic ventricular tachycardia, right? What happens in polymorphic VT is, they're like all the QRS complexes, they are different in morphology, right? So it's like this. So you will get an ECG like this. So the amplitude of all of the QRS complexes, they are not same. So they are different, right? So amplitude of all QRS complexes, they are different. And doesn't it look like a ribbon, right? A ribbon pattern. So we call it polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. And classically this is known as torsades de pointes. Torsades de pointes. Okay. For treatment of torsades de pointes, we usually go for magnesium sulfate. Okay. For treatment of monomorphic ventricular tachycardia, if the patient is stable, unstable, so the treatment vary about the patient's hemodynamic stability. So it depends on that. We can use lignocaine, we can give DC shock. So these are the mainstay for treatment of monomorphic ventricular tachycardia, and for polymorphic ventricular tachycardia, you can use magnesium. Okay. So I hope till now we know the difference between how to differentiate between ventricular tachycardia and supraventricular tachycardia. Then comes atrial fibrillation. So in atrial fibrillation, what happens is, so there's fibrillation of atrium, okay, fibrillation of atrium, atrial fibrillation, right? So what does fibrillation mean is the atrium are not contracting normally, so they are just fibrillating, right? So there are atrial fibrillation. So in ECG there will be no P wave, right? Because there's no atrial contraction, but there are ventricular contractions that might come in between. Okay, so in what will be the ECG findings of atrial fibrillation? There will be P wave absent, or and instead of P wave there will be fibrillatory waves. Right? What does fibrillatory mean? Like this. So there's something, but they are not P waves. Right? And in between you will get QRST complex. So there will be ventricular contractions present. Ventricular contractions present. The presence of QRST wave indicates presence of ventricular contraction. And RR is irregular. So that's irregular RR intervals like this. So this is 1 hour, second hour, third hour. So all RR interval will be different. Okay. So in any ECG, if you find absent P wave plus irregular RR interval, RR interval. So they're like RR interval, they are irregularly irregular. Right. So R wave can come at any place. Then this will be the diagnosis for atrial fibrillation. So for treatment of atrial fibrillation, we use a race therapy. What does race means is we give some rate controlling drugs. These rate controlling drugs can be beta blockers. We can also use amiodarone in case of atrial fibrillation, right? We will give anticoagulants. These anticoagulants are very important in case of atrial fibrillation. I'll explain you why. See, so this is normal heart. This is left atrium, right ventricle, and left ventricle. So normally these atria, when they contract, all the blood goes to left ventricle, right? And there's very minimal blood left in left atrium, right? And all the blood goes to left ventricle, and then the blood goes to aorta. So there's no stasis of blood. So there's like the blood never stops at any place, right? But in case of atrial fibrillation, atrium won't be contracting so strongly. So there will be fibrillation of atria, right? So there will be hemostasis. There will be some stasis of blood. So blood will be there, like some blood will left in left atrium, right? And this will cause thrombosis formation. Thrombosis formation. All the thrombos, I'll change the color. If there's some thrombus forms, so they might go to left ventricle and then to aorta and then to any part of body. Any part of body getting blood supplied from aorta, right? And they can cause ischemia over there. So what will happen to this thrombus? We call it thromboembolism. Thromboembolism. Understood? So because see, I'll explain it again. So we have a patient of atrial fibrillation. So we know by pathophysiology that there's increased risk for thrombus formation. Thrombus formation, increased risk. If these thrombus will form, they can go to at any place. We'll call it thromboembolism. And what are the most common site for thromboembolism is they can go to brain and cause ischemic stroke. And for Krok question, they have specially given a patient of atrial fibrillation, and then he suddenly feels pain and pain lower limb. So there will be acute pain in lower limb, and on objective examination you find that that lower limb is pale and there's no pulse, so there will be pulseless. Okay, so that means there's thromboembolism of lower limb, right? And at other places also this thrombus can go to at any place. Okay, so we'll call it thromboembolism. This is increased risk for atrial fibrillation is increased risk for thromboembolism, and that's why we give anticoagulants. If the patient responds good to these drugs, then we don't need to go for chemical defib, but we can, if patient might need, we can go for chemical defibrillation or electrical defibrillation. Okay, so just remember the ECG for atrial fibrillation, which is absent P wave and irregular RR intervals. Then for treatment part, remember rate controlling drugs we can use, and anticoagulants are very important. So they are given as a prophylaxis of thromboembolism. Okay, then we can go for chemical defibrillation and electrical defibrillation, right? Then comes atrial flutter. So the ECG for atrial flutter will give you a keyword. Okay, so there's a keyword for atrial flutter, and that is sawtooth pattern. Sawtooth pattern of P wave. I'll explain what does this sawtooth pattern of P waves mean. Let's say this is a P wave, again a P wave, and then QRST comes. Then again a P wave, and then again a QRST comes. Right. So in what happens in atrial flutter is there's atrial contraction, and one impulse it goes to ventricles via AV node, right? So out of these 3-4 impulses, only one impulse is conducted to QRS to ventricles, right? Then comes another P, and out of these 3 impulses, only one impulse is conducted to ventricles, right? So in atrium, there generation of multiple impulses, and out of them some impulse are conducted via AV node to ventricles, right? And these P waves, multiple P waves, they give this classical appearance of sawtooth pattern. So we name them sawtooth pattern of P waves, right? And this is a classical finding for atrial flutter. The treatment for atrial flutter will be absolutely same, race therapy, and we have discussed this therapy, rate limiting drugs, anticoagulants. That's same thing, okay, which we have used in atrial fibrillation, right? So till now in ECG, we have discussed AV blocks, supraventricular tachycardia versus ventricular tachycardia, then atrial fibrillation and atrial flutter. Right. For supraventricular tachycardia, so we talked about ventricular tachycardia. There's monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, right? For supraventricular tachycardia, there's narrow QRST. There's one more diagnosis which we get in Krok questionnaire. There's paroxysmal supraventricular tachycardia, or PSVT. PSVT is paroxysmal supraventricular tachycardia. Okay, so what happens in paroxysmal supraventricular tachycardia is we get a patient of tachycardia for sure. Okay, by name we understood there's QRS narrow. because they are supraventricular tachycardia, and there's merging of P and T wave. P and T wave merge. And why do these waves merge? Okay, let's say this is normal PQRS T. Again PQRS T. If in this patient there will be tachycardia, this R and R will come, like they'll come nearer to each other, right? And these P waves and T waves, they will merge with each other because of this tachycardia. So they will look like this, right? I'll make I see here again. So this will be the ECG for. So what happens in PSVT is we get a QRS complex, and then this complex. Okay, this is made by merging of T and P wave, merging of T and P wave. Okay, and we call it PSVT, paroxysmal supraventricular tachycardia. Okay, treatment part also I'll cover here. So for treatment of PSVT, we usually give adenosine, or we can do cardioversion. Right. So in Krok exam, they will only use this medical therapy. So they like to ask about drugs, right? So they'll ask you the treatment for PSVT will be, and you'll answer adenosine, right? Yes. So we have completed AV blocks, SVT, VT, atrial fibrillation, atrial flutter. Right. Let's talk about hyperkalemia. Hyperkalemia. Right. So hyperkalemia means there's increased serum potassium levels. Right. So the normal potassium levels are 3 to 5 milliequivalents per liter. So these are the normal potassium levels. If they are increased, okay. So what can be the causes of hyperkalemia? Usually there are some renal causes. Okay, there can be many other causes for hyperkalemia, but usually there are some renal causes, because if there will be some problem in kidney, there will be no potassium excretion, right? So the patient can be of CKD, chronic kidney disease, right? There can be a patient of acute kidney injury, chronic kidney disease, acute kidney injury. See, in Krok question also, if they want to ask about hyperkalemia, they usually go for questions mentioning patients of some renal disorders, right? So these are the main causes of hyperkalemia. And what will be the changes in ECG will be? So in case of hyperkalemia, there will be, firstly I'll make a normal ECG, right? So in patients of hyperkalemia, there will be T wave going up and P wave going down, and there will be bradycardia. Okay, so three changes: bradycardia, P wave will go down, and there will be toll tented T waves. This is the term they use, toll tented T wave. And I'll make the ECG here for hyperkalemia. So there will be P wave very small, R wave, and then T wave also looks like R wave. Then again very small P wave, QRST, and then T wave. Right. So T wave, they look, so these are the T waves, right? These are the T waves. Yeah, I'm marking. They are toll tented T waves. They are toll tented T waves. There's P wave going down, and there can be bradycardia. So these are the findings we usually get in patient of hyperkalemia in ECG. Okay. For treatment of hyperkalemia, we usually give 10 ml 10% calcium gluconate. See, in patient of hyperkalemia, so it is very hard for heart to keep pumping. Okay, so if it is hard for heart to keep pumping, we give calcium gluconate so that there will be no like cardiac failure. Okay, and for For decreasing the level of potassium in blood, will give insulin plus glucose. We can also use beta 2 agonist for this purpose, and the best treatment for hyperkalemia is hemodialysis. So you will take the patient to the dialysis unit, and then the patient's potassium level will come to normal. Okay, so these are the main 4 treatments for a patient of hyperkalemia. For hypokalemia, the ECG changes will be absolutely opposite to them. So there will be P wave increase, P wave amplitude increase. There will be T wave amplitude decreases, or there will be inverted T waves, and there will be tachycardia. These are main things. Okay, so in hypokalemia, this is the normal ECG. This T wave will go down and P wave will come up. So this will look like this. Right? This is exactly opposite what we have seen in patients of hyperkalemia. Okay. For treatment of hypokalemia is you give KCA. So there's low potassium level in the serum, so you give potassium chloride injections. Okay. Before moving to MI, I'll cover pulmonary embolism also. Pulmonary embolism. See, I'll quickly explain what pulmonary embolism is. Let's say there's any patient of deep venous thrombosis. So in the lower limbs, there are some thrombus formation in deep veins, and this is deep veins. Okay. Here we have heart and lungs. Okay. Let's say a patient have deep venous thrombosis. So this thrombus can go to heart and then to lungs. Right. So this is known as pulmonary embolism. So pulmonary embolism means any embolism which have come to pulmonary vessels. Pulmonary vessels. Okay, and this usually comes from deep veins of leg. Okay, for asking the question for pulmonary embolism, they'll give you history for deep venous thrombosis, right? So in ECG, we usually read this S1, Q3, T3, right? In many Krok questions they are given in ECG, you get S1, Q3, T3. This is the classical presentation for pulmonary embolism. Pulmonary embolism. I'll explain what this S1, Q3, T3 means, right? So in a patient of pulmonary embolism, when we do ECG, okay, we get S1, Q3, T3. In S1, Q3, T3 means, I'll show the ECG ones, yes. See, this S1, Q3, T3 means, T3 means there's deep S wave in lead 1, and in lead 3 there will be deep Q waves and inverted T wave. See here, you can see in this ECG we can see deep S wave, right? And in this in lead 1 and in lead 3 we can see deep Q waves and inverted T wave. There's T wave inversion. So this is S1, Q3, T3 pattern which is seen in cases of pulmonary embolism. Okay, so for the question of pulmonary embolism, they'll give history of deep venous thrombosis. They'll give clinical presentation of acute chest pain. Okay, and in ECG findings, they will give S1, Q3, T3. Okay, and they can also give echo findings. Echo findings is acute core pulmonary. For treatment, for treatment of pulmonary embolism, we usually use heparin. Okay, we usually use heparin 80 international units per kg. But we can also do thoracotomy, thoracotomy, or we can do embolectomy, embolectomy and heparin. See, so this treatment, it depends on the condition of the patient. If the patient with pulmonary embolism is stable, okay, we'll use heparin. If he is vitally unstable, okay, so if there will be hypotension in the patient, we might need surgical procedures like embolectomy, thoracotomy. Okay, so we might need this surgical procedures, but if the patient is vitally stable, we might go for medical treatment as well. So this is the treatment for pulmonary embolism and the ECG findings. Then the main use of ECG for diagnosis of myocardial infarction. See, for diagnosis of myocardial infarction, we can get three things. Okay, so there will be a clinical presentation of a patient. So what is the clinical presentation is? The patient usually comes to, like, old patient usually comes to you with complaints of chest pain, radiating to left arm, radiating to left arm, left shoulder, or to jaw. Right. So the pain can radiate to left arm, left shoulder, and jaw. Right. This is the clinical presentation. This is the classical clinical presentation for myocardial infarction cases. Then, in any patient of chest pain, you do ECG. Right. In ECG, there will be ST segment elevation. Okay, I'll tell you what ST segment is. So this is normal PQRST. This is PQRST. So this segment between S and T is ST segment. And in ECG of myocardial infarction, you will get this ST segment elevated. Right. So the ECG might look like this. Okay. So this is the ST segment elevation. And this ST segment elevation is convex in shape. Okay, with ST segment elevation, there can be hyperacute T waves also. Hyperacute T waves. Okay, so I'll make an ECG here. See. So, and hyperacute T waves mean like this. They are different from what we get in hyperkalemia. In hyperkalemia, we get tone-tented T waves. Tone-tented T waves. They look like this, right? And in MI patients, so in patient of myocardial infarction, they use the word hyperacute T waves. Hyperacute T waves, and they look like this, right? There can be ST segment elevation also in patient of myocardial infarction. Okay, so till now we have studied like in myocardial infarction. If we will do ECG, okay, there will be ST segment elevation. There can be hyperacute T waves present, right? T waves present. You'll do cardiac biomarkers also. Cardiac biomarkers means troponin T, troponin I. So these cardiac enzymes, they will be increased in case of myocardial infarction, right? So if any patient if any patient, any old patient, I'm taking the classical case scenario, okay? Old patient complaining of chest pain, radiating to left arm, left shoulder, and jaw. You have done ECG, okay? And now there are ECG changes also present, okay? So we all study there can be ST segment elevation MI, which is classical, okay? We get ST segment elevation in this. There can be non-STEMI also. So we get ST segment depression. So ST segment depression means there's, see, this ST segment is depressed in this case, right? It should be here. This is the normal iso electric line, and they are depressed. So if ST depression is there in a patient of this classical MI presentation, okay, we'll do cardiac biomarkers in this patient. Cardiac biomarkers, they are also increased. We call it non-STEMI. Okay, so for diagnosis of MI, there should be clinical presentation, there should be ECG positive, plus there should be cardiac biomarkers increased. And this is very important, cardiac biomarkers increased. This cardiac increase in cardiac biomarkers will tell you that this is definitely MI. Okay, so how MI is different from angina? So we'll start angina here. Okay, see. So we have three types of angina: stable, unstable angina, and Prinzmetal angina. So in all the previous year paper, we mainly got questions from stable angina, unstable angina, but in May 23, we got question from Prinzmetal angina also, right? So I'll try to make a table to differentiate them. Okay, I'll make a new table. So stable angina, unstable angina, and Prinzmetal angina. See, to differentiate them. So what is angina first of all? So angina pectoris, we read this term, right? Angina pectoris. So this is simply chest pain. So any patient coming to you with chest pain, this is not necessarily that that patient has myocardial infarction. There can be angina pain also. Okay, so how do we differentiate this angina pain with myocardial infarction? See, if the patient's pain is related to exercise, right? See, angina pectoris is chest pain. This chest pain is usually relieved after some time, in then we call it angina only. And if this chest pain is not relieved even after 1-2 hours, then we should suspect MI. Okay, there will be some different lab values also, so we'll study them. First of all, how to differentiate between stable, unstable, and Prinzmetal angina. So in stable angina, there will be chest pain related to exercise. So patient will complain you whenever I do exercises. So whenever I go to park, I walk for 500 meters, I walk for 600 meters, I get pain. I get chest pain, okay. And whenever I sit in the park, then my chest pain is relieved. So chest pain is relieved at rest. In unstable angina and Prinzmetal angina, chest pain can arise at rest also. So they are not related to exercise. Okay, then in unstable angina, so we'll do ECG. Okay, whenever a patient complains of chest pain, we do ECG. In stable angina, there can be ST segment depression. So there can be ST segment depression. In unstable angina also there can be ST segment elevation. But in Prinzmetal angina, there's ST segment elevation. So here ST segment depression. In unstable also ST segment depression. In Prinzmetal there will be ST segment elevation. Right? That's why we call Prinzmetal variant angina also. Why do we call it variative? So in normal, the most common anginas which we see in our daily life is stable angina, unstable angina. So whenever we do ECG in cases of stable angina and unstable angina, there will be ST depression. But in case of transmental angina, there can be ST segment elevation. So this is the question which we got in May 23 exam is there's one patient of chest pain, and when we do ECG there will be ST segment elevation. So this can be transmental angina or MI. But when we do cardiac markers, they will be normal in all type of anginas, right? So because this is not MI, so there's no particular damage of a myocardiocite, so there will be no enzyme leakage in the blood. So there will be mainly cardiac and biomarkers normal. Okay, so I'll tell you quickly like transmental angina. Okay, so in transmental angina, patient will complain of chest pain, right? At rest, there will be ECG findings of ST segment elevation, and on if you do cardiac biomarkers, they'll be normal, right? If you do angiography also, there this will be normal. Why? See, in transmental angina, this is vasospastic condition. Vasospastic condition. What does vasospastic condition means? Is this is normal coronary vessel in stable angina, unstable angina. We usually study about some plaque formation. So in stable, unstable angina, usually there are some plaque formation, right? Plaque formation. So there is some physical obstruction present. Two blood flow towards myocardiocytes, right? So physical obstruction present, right? But in case of vasospastic angina, there's no physical obstruction present, but there's vessel spasm. So there will be vasoconstriction. So there's vasoconstriction present, which is relieved after some time, and the patient's pain will go away. Right. For the treatment of transmental angina, we can prescribe calcium channel blockers like nifedipine, so that the vessel of the coronary vessels won't constrict. Okay, we can also use nitrates. Right? So these are the main treatments for mainstay for transmental angina. So we read about anginas. Okay, we have stable angina, unstable angina, and transmental angina. Stable angina, this is related to exercise. There can be ST segment depression, and the cardiac biomarkers will be normal in all of the anginas. Okay, in unstable angina, the pain usually arises at rest. There will be ST segment normal or depressed, and there can be the cardiac biomarkers will be normal. Okay, and in transmental angina, the pain can arise at rest. The pain usually occurs in the morning time, mainly in the morning time. Okay, because in the morning this is the cold time. Okay, and the vessels they are more likely to go under constriction during this time. There can be ST segment elevation, and the cardiac biomarkers will be normal. Okay, for the treatment of transmental angina, we have read about CCBs, calcium channel blocker, and nitroglycerin. Okay, nifedipine, amlodipine, these drugs. So as we are done with ECGs, okay. ECGs we are done, okay. So now just we were studying about MI, na. So we'll cover post MI complications also right now. Post MI complications. Okay. So there are three complications which are very important for Krok exam. The first one is acute left ventricular aneurysm. Give me a second. Okay. Acute left ventricular aneurysm. Okay. The second one is acute pericarditis. And the third one is Dressler syndrome. I'll explain them. Restless syndrome. Okay, so let's say this is left ventricle. Okay, this is left ventricle. In left ventricle, sometimes we got inferior wall MI, sometimes we got lateral wall MI, sometimes posterior wall MI, anterior wall MI. We can get in septal MI. Okay, so there are many like there are many locations where we can get a myocardial infarction. Okay, so let's say wherever there will be myocardial infarction. So let's say we have got a patient of lateral wall MI. Okay, so the lateral wall of the left ventricle, the patient is got MI over there, right? So whenever we get a patient of some particular wall, so there will be definitely weakness in the wall. See, there will be weakness, and whenever the blood will come, it will put pressure on this wall. So the wall is weak right now, and it can undergo aneurysm. Aneurysm is usually dilation of normal vessel or structure. Right. I'll show you the diagram, then we'll discuss about it. See. Hmm. Let's say this is the echo of left ventricular aneurysm. Okay. So the normally left ventricular wall should be like this, right? But in this patient's echo, we have got a dilation, outpouching, outpouching after MI attack, right? We call it left ventricular aneurysm. Okay. In Krok question, Krok 2 question, for explaining acute left ventricular aneurysm, they'll use a keyword with paradoxical pulse. So they'll explain like a patient of MI. Now we have done like we are doing objective examination and we are getting paradoxical pulse 2 centimeter from apex. Right. What does it mean is usually we get the pulse, main pulse at apex, right? And now if in the patient this wall is weak and it will be like this, so we'll be getting a paradoxical pulse here also, right? We'll get a pulse here also, and this will be known as paradoxical pulse. And in the Krok question, they'll specifically mention that the paradoxical pulse is present 2 centimeter from apex or 2 centimeter from mitral area. Okay, understood this acute left ventricular aneurysm, right? Second complication is acute pericarditis. So acute pericarditis is usually a week, 1 week after MI. So after 1 week of myocardial infarction, if we get a patient complaining chest pain, there can be fever, right? And on objective examination, you will get pericardial friction rub. Pericardial friction rub. So you can get to know that this is a patient of acute pericarditis. Acute pericarditis can also occur after viral infections. So it is not mandatory that it will occur after myocardial infarction also. This can occur in viral infections also, right? So after viral infection, you'll get a patient of chest pain, fever. There can be pericardial friction present. So you'll get to know that this is acute pericarditis. Okay. And the third one is Dressler syndrome. Dressler syndrome. So Dressler syndrome is usually it usually occurs 3 to 4 weeks after MI. So it takes time to occur. Okay, and this is autoimmune process. So this is autoimmune pericarditis. Okay, so in the Dressler syndrome also we will get the same symptoms like chest pain, there will be pericardial friction drum, but this will occur after 3 to 4 weeks of MI, right? Till now, in Krok 2, they have asked questions on acute left ventricular aneurysm and acute pericarditis, but this Dressler syndrome they are used in options, in other options, so they might ask about Dressler syndrome also. Okay, then what else? Okay. Let's study cardiac tamponade. Cardiac tamponade. Okay. So in cardiac tamponade, see, this is the normal line. This is the normal heart, and around the heart we have visceral pericardium, which is covering the heart, and there's parietal pericardium, right? Parietal pericardium. So normally we have pericardial fluid between visceral and parietal pericardium. This is to prevent heart from shocks, like from outside trauma. This is pericardial fluid. And normally this pericardial fluid is around 50 ml, 50 ml, 100 ml. Okay, this is in very small amount. If by anyhow this pericardial fluid amount, it will rise up to 500 or 1000 ml. If there's acute rise in pericardial fluid amount, we call it cardiac tamponade. Okay. See. So for patients of cardiac, like for question of cardiac tamponade, they'll start with any patient of trauma. So there might be some bleeding inside pericardial cavity, and all the blood will accumulate suddenly inside the pericardium, right? So there will be some history of trauma like car accident or some boxing going on, and there's some direct hit in the on the heart area, right? So there can be damage of pericardial small vessels. Okay. Then patient on objective examination will get hypotension. So if there will be fluid accumulation around heart, okay, in cardiac tamponade there will be massive fluid accumulation around the heart. Now it will become very hard for heart to keep pumping normal amount of cardiac output, to give normal amount of cardiac output. It will be very hard for the heart. Okay, so the patient on an objective examination we can find hypotension. There can be raised jugular venous pressure. What jugular venous pressure is? See, we get jugular veins. Okay, so in these jugular veins, so jugular veins they take blood from cephalic part, from the brain. Okay, and they deliver this blood to right atrium. If this right atrium is constricted because of some pressure from outside, these jugular veins won't be able to deliver blood to right atrium, and then there will be increased jugular venous pressure because the blood will accumulate in jugular veins. There will be hepatomegaly also, because this right atrium it gets its blood from jugular veins, from inferior vena cava also, right? Inferior vena cava gets its blood from liver, from abdominal cavity. So there will be blood accumulation everywhere. So hepatomegaly. See, in patient of pericardial temp, in patients, right. So in patients of cardiac tamponade, they'll give history of trauma presenting with complaints of hypotension. On objective examination, you are finding these things. On objective examination, there can be raised GVP and hepatomegaly. This is known as Beck's triad. Okay, this is specific for cardiac tamponade. Okay, and you can do echo for confirmation of diagnosis, and in echo you will see there's rise of pericardial fluid amount. I'll show you the echo also. Hmm. So in echo you can see normally there should be very less amount of pericardial fluid should be present, but in this echocardiography you can see there's large amount of pericardial fluid present, so you can make the diagnosis of cardiac tamponade, right? So echo you can do investigation of choice. Investigation of choice for cardiac tamponade is echo, and for treatment you'll do pericardiocentesis. Pericardiocentesis. Pericardiocentesis means taking out the extra amount of fluid from pericardial cavity, right? And this is usually done ultrasound guided. So we, for treatment part, we usually write ultrasound guided pericardiocentesis. Okay. So till now we are done with ECG, we are done with post MI complications, and we have studied this cardiac tamponade. Okay. Now for questions of myocarditis, so we studied pericarditis, right? So there can be myocarditis, there should be infective endocarditis. So for patients of myocarditis, they will they will present with classical complaints of chest pain, right? And on objective examination, if you do ECG, there will be arrhythmias, and they will also give history of some viral infection. Okay, so if in the question they start that a patient had viral infection few days back, now he's complaining of chest pain, and on ECG you find some arrhythmia, the patient might complain of some palpitation also, you should mark myocarditis in that, right? So the correct answer will be myocarditis. In pericarditis can also occur after some viral infection, but there will be pericardial friction rub, no arrhythmias like this. In infective endocarditis questions, firstly they will give you the source of infection. So usually the source for infection can be the patient can be a IV drug abuser. Okay, so in IV drug abusers, whenever they inject, so there's increased risk for bacteria to go inside the bloodstream. Okay, there can be some history of tooth extraction during some surgical procedure. Okay, there can be any surgical procedure. So these things they increase risk for endocarditis, for infective endocarditis. Right. So for the question of infective endocarditis, they'll give you a source of infection. Right. Then this patient will present to you with fever and some cardiac sign and symptom. Okay. If you suspect infective endocarditis, you'll do echo. Right. And echo, there will be some valvular vegetation. Let's say this is left ventricular and this is mitral valve. This is mitral valve. So there are like two cusps. Mitral valve. On echo, you can get some vegetations present. Right? Vegetations present. So we'll make the diagnosis of infective endocarditis. Endocarditis. Echo, apart from vegetation, there can be some mitral regurgitation also. So some valvular deformities can be also present because of these vegetations. Okay. So this is infective endocarditis. So we'll quickly revise infective endocarditis. Then there should be a source of infection, IV drug abuser, tooth extraction, surgical procedure. The patient will present with some classical cardiac signs, symptoms. There can be fever also. On echo, you can get vegetation, some valvular pathology like MR, and you'll make a diagnosis of infective endocarditis. We usually use modified Duke's criteria. Okay, and they have in Krok 2 questions, so they have never asked about this. So I'm not going into depth for modified Duke's criteria for diagnosis of infective endocarditis. Right. For myocarditis, there will be some viral infection, then the patient will complain of chest pain and chest pain palpitation, and you will see arrhythmias in the patient, right? So you can make the diagnosis for infectious myocarditis. In one question, they have given answer infective allergic myocarditis also. Myocarditis also. But I don't know like what's the reason for allergic here, okay? But you can mark that question infective myocarditis because they are given viral infection history, then we'll say arrhythmia, chest pain, palpitation, then you can easily make the diagnosis for myocarditis. Okay. After myocarditis, infective endocarditis, we'll cover murmurs, okay? Let's study about murmurs right now. Murmurs. So murmur is any abnormal sound which is generated by blood flow. Generated by blood flow. Right. I'll try to quickly cover murmurs. Okay. See, we have. I'll try to simplify things also. So this is right atrium, right ventricular, left atrium, left ventricular. We have mitral valve here. We have aortic valve here, we have pulmonary valve here, and we have tricuspid valve. So these are the four main valves of the heart, right? We all know about this. So, see, this systolic murmurs. See, these systolic murmurs. So there are two murmurs, right? Systolic murmurs and diastolic murmurs. Systolic murmurs usually arise when there is some contraction of ventricles producing murmurs. So there are some murmurs, production of murmur during contraction of ventricles, and if murmur present during relaxation of ventricles, we call them diastolic murmurs. Okay, see. If ventricle is contracting, okay, so there's ventricular contraction, and if it is like if there's some problem in outlet in blood going out of the left ventricle, it will produce murmur. Let's say this aortic valve, okay, let's say this is left ventricle and this is the normal diameter of aortic valve. The blood is going to aorta, right? If anyhow this aortic valve, the lumen of the aortic valve is narrowed, now all the blood going towards aorta will go with production of some sound. We call it murmur, and this is occurring at the time when the blood is being pushed out from left ventricle. So this is systolic murmur. So systolic murmur means murmur arising during systole of the ventricles, right? So systolic murmur, right? And there can be diastolic murmurs also. So I'll give you the example of diastolic murmur is when the left ventricular is relaxing. Okay, see, normally left ventricular it gets its blood from left atrium, right? If there's some mitral stenosis, so during relaxation of left ventricular, when it gets blood from left atrium, right? So if left atrium, it is pushing blood into left ventricular, but there's very narrow opening of mitral valve. So the blood will go with production of some sound, and we call it diastolic systole that time. So all the murmurs, any murmur arising during the systole of the ventricle, we call it systolic murmur. Any murmur arising during diastole of the ventricle, we call it diastolic murmur. Okay. So for systolic murmur, there can be atrial stenosis, there can be mitral regurgitation also. Okay. So the left ventricle, it is like during the systole, all the blood should normally go towards aorta. But if there's some problem of mitral valve regurgitation, right? If the mitral valve is not closing properly, we call it mitral regurgitation, or mitral insufficiency, it is the same thing, okay? Insufficiency. We call it mitral insufficiency. Okay. If there's no proper closure of the mitral valve, see, normally mitral valves should close like this. There's one cusp and there's another cusp. And let's say this is left atrium, this is now left ventricle. During the systole of the left ventricle, all blood should go this side and no blood should go this side, okay, because these cusps are closed. If there's some problem with these mitral valve cusps, okay, if the cusps are like this, they are not properly closed, blood will go up during ventricular contraction and this will produce systolic murmur, okay. So on the left side we can get systolic murmur in case of aortic stenosis and in the case of mitral regurgitation. On the right side we can get in the case of pulmonary stenosis and tricuspid regurgitation. Similarly, diastolic murmur will be seen in aortic regurgitation, mitral stenosis, so exactly opposite to them. Pulmonary regurgitation and tricuspid regurgitation. Tricuspid regurgitation, tricuspid stenosis. Okay, so diastolic murmur will present in aortic regurgitation, mitral stenosis, pulmonary regurgitation, and tricuspid stenosis. Okay, so for clearing any question of murmur, we should be knowing two things. So firstly, we have discussed type of murmur, right? Whether if type of murmur, whether it is systolic murmur or diastolic murmur. The another thing we have to look for is the location of murmur. If we know these two things, we can easily tell, okay, this murmur belongs to this valvular defect, or okay, and these things can happen. See, normally we don't know location of different valves, okay, aortic valve, pulmonary valve, tricuspid valve, and mitral valve. Normally we auscultate at these places, right? So the location of atrial valve is second intercostal right parasternal line. Pulmonary valve is second intercostal left parasternal line. Tricuspid is fifth intercostal left parasternal line. And mitral valve is, which we also call apex, okay, it is fifth intercostal mid clavicular line, right? So if you know the location of murmur and you know the type of murmur, you can easily tell which valvular defect we have. Okay, let's say you have got systolic murmur at apex. See, at apex we have mitral valve, and in which mitral valve pathology we get systolic murmur is mitral regurgitation. Okay, so we can tell in mitral valve there will be mitral regurgitation, or also known as mitral insufficiency. So by knowing just two things, the location and the type of murmur, you can easily solve any question of murmur. Okay, there are some special murmurs which we need to talk about separately. Is there's murmur for ventricular septal defect. We know ventricular septal defect is there's right ventricular, left ventricular, and we have a septum there, right? If there's some defect in that septum, if there's some defect in the septum, we call it ventricular septal defect. And the murmur for ventricular septal defect will be pansystolic murmur. Pansystolic murmur, which is usually at third or fourth intercostal space. So we'll get the murmur for VST is here. So I'm making this diagram. The murmur for VST will be here. Okay. We also read this patent ductus arteriosus, PDA. Patent ductus arteriosus. right? So in patent ductus arteriosus, we usually get machinery murmur, or in some questions they might mention it as continuous murmur. Sometimes they have also written systolo-diastolic murmur, right? So why do we call them machinery murmur, continuous murmur? Is, see, this is the period of systole, then comes diastole, systole, diastole. Some murmurs they can be systolic murmur, some can be diastolic, but in the case of PD, you get murmur during all the time, and this produces the sound of a machine working. Okay, that's why we call it machinery murmur, continuous murmur, or systolo-diastolic murmur. And this we usually get in cases of PD. Okay, so as we are done with the ECGs, we are done with cardiac tamponade, post-MI complications, angina, infective endocarditis, myocarditis, and murmurs. Let's quickly study about tetralogy of Fallot also. Okay, so this is tetralogy of Fallot, right? So this is a pediatric condition usually, pediatric condition. So what are the four? See, this is tetralogy. Okay, so there are four defects of heart. Defects of heart seen in children. If any children with these four defects present, we call them tetralogy of Fallot, right? These are the four defects. What are the four defects? There's pulmonary valvular stenosis. Then there's pulmonary valvular stenosis. There will be right ventricular hypertrophy. There will be ventricular septal defect, and there will be overriding aorta. Overriding aorta. You have to remember these by yourself. Okay. So there's pulmonary valvular stenosis. There's right ventricular hypertrophy. There's ventricular septal defect, and there's overriding aorta. In tetralogy of Fallot also we get to some murmur. Okay, and this murmur can be because of this pulmonary valvular stenosis mainly. Okay, so we can also get systolic murmur in case of patients of TOF. Okay, but for calling it as a tetralogy of Fallot, we should be having all these things. Okay, all four these effects. Okay, then we'll talk about hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. See, I'll try to explain these conditions in very simple words. Okay, firstly I'll show you the image. See, so normally this interventricular septum, this the wall of the left ventricular is normally 1 centimeter thick. Okay, but in patients of hypertrophic obstructive cardiomyopathy, so there's hypertrophy of left ventricular wall. Right, see, this left ventricular wall is now 2 or 3 centimeter thick. So this is thick wall. That's why we call it hypertrophic. And why we call it obstructive is, see, this is the AV, this is the aortic valve area, right? This is the passage for blood to go from left ventricular to aorta. I'll change the color. See, this is the normal passage for blood to go from left ventricular to aorta. Right? If this septal will keep on thickening, so it will cause obstruction in left ventricular outflow. So there will be left ventricular outflow obstruction. If there will be left ventricular outflow obstruction, it will behave like aortic stenosis, and in this condition also we'll get murmur of, we'll get systolic murmur. Okay, so in patients of hypertrophic obstructive cardiomyopathy, they'll start with giving history of some sudden cardiac death in family members. So because this is an inherited condition, so there will be some history of sudden cardiac death in family members. So you can get to know that there is some inheritance in this case, in this condition. Okay, then the patient will complain of that classical chest sign and symptoms. There will be some chest pain. In echo, you'll find asymmetrical septal thickening. Asymmetrical septal thickening, and this is a keyword for our Krok exams. Okay, if in any patient's echo you'll get asymmetrical septal thickening, and there's sudden history of sudden cardiac death, classical sign and symptom of heart disease, then you can make the diagnosis of HOCM. For treatment of hypertrophic obstructive cardiomyopathy, usually is beta blockers like metoprolol. Okay, this was HOCM. Then we'll quickly talk about hypertension. See, for when do we call hypertension? Okay, so normal blood pressure of any patient is 120. If the blood pressure of any patient is more than 140/90, we call it hypertension, right? So there are some stages of hypertension. There's stage 1 hypertension when the blood pressure is from 140 to 159 systolic blood pressure, and the diastolic blood pressure is 90 to 99. Stage 2 hypertension is when there's blood pressure of 160 to 179 systolic and 100 to 110 diastolic. Okay, this is easy. So this is a classification for hypertension. But in Krok exam, we need to remember that for stage 1 hypertension patient, that is having blood pressure of 140 to 159 systolic blood pressure, we usually do follow-ups twice a year. Twice a year follow-up. Okay. So twice a year follow-up. When, like, let's say you got a patient of stage 1 hypertension, you will call him for follow-up after 6 months. So every 6 months the patient has to come for follow-ups, right? So there will be follow-up twice a year. For patients of stage 2 hypertension, there will be follow-up 4 times a year. So there will be follow-up 4 times a year. So you'll call the patient in every 3 months for follow-ups, right? So this stage 1, stage 2 hypertension is clear. There's something known as hypertensive urgency and hypertensive emergency. Urgency and emergency. See, whenever you get a patient with blood pressure readings more than 110, 180 or 110, so you can definitely tell that either this is hypertensive urgency or emergency. So blood pressure more than 180, 110, this can be urgency or emergency, right? But if in a patient having blood pressure, let's say 220/120, this is high, very high blood pressure, right? If there's no end organ damage present, then we call it, see, because of this hypertension there's no organ damage, then we call it uncomplicated hypertensive emergency or urgency. The word uncomplicated is very important here, because there are no complications because of this increased blood pressure, right? If the patient has blood pressure more than 180, 110 and there's present end organ damage, we call it complicated hypertensive. We call it complicated hypertensive emergency, right? I'll tell you this end organ damage. Let's say any patient presents to you with blood pressure 220 or 120, right? You know this blood pressure is very high, so there can be some vessel rupture also. So if there's some problem in brain if present, so there can be hemorrhagic stroke. We check retina. If there are some complication, there can be retinal detachment because of hypertension. What can be the complication in kidney? There can be acute kidney injury. In lungs, there can be pulmonary edema. In heart, there can be myocardial infarction. Right. So these are the end organs. If the patient has, if the patient presents to you with blood pressure this much, if any one of these present, anyone present, we call it complicated hypertensive urgency. This word complicated is very important because if the patient has pulmonary edema, this is because of hypertension. If the patient develops retinal detachment, this is because of hypertension. So there are some complications present because of this increased blood pressure. We call it complicated hypertensive emergency. If there's no end organ damage, we call it hypertensive urgency. In the last, I'll finish with pulmonary edema treatment. Okay, so for the clinical presentation, so we know pulmonary edema can be, there can be cardiogenic reason also. There can be some cardiogenic reason. Okay, the most common reason for pulmonary edema is cardiogenic. Okay, the clinical presentation will be dyspnea on exertion. Okay, you do objective examination, dyspnea on exertion or dyspnea of any kind. Okay, they will tell you that there's some lung pathology. Okay, on objective examination you will get bilateral crackles in lower lung fields. Okay, see, this is lungs, right? Whenever there's some cardiac issue, there will be some fluid accumulation here in the lower fields because of gravity. Okay, and you auscultate these fields, there will be some crackling sound, rails present. Okay, there can be some rails present. Then we call it pulmonary edema. Okay, we call it pulmonary edema. Okay, one second. Shit. So guys, for the treatment of pulmonary edema, we usually use this regime of LMNOP, right? So what does LMNOP means? So we can use Lasix, we can use morphine, we can use nitroglycerin, we can use oxygen, and we can do positioning of the patient for treatment of pulmonary edema, right? I'll quickly write it here. So for treatment of pulmonary edema, we can use a regime of LMNOP. L means Lasix. So you can use furosemide, torsemide. You can use morphine. In the Krok question, they have mentioned a drug promidol, which is an analog of morphine. You can use nitroglycerin, you can use oxygen, and you can use positioning. In the Krok question, they have given a patient of pulmonary edema and they have asked the treatment. So treatment for that patient will be promidol. Okay. So we'll finish our session. I hope this session will be useful for you guys. Okay, thank you.